I'm Jason Fallhaber, one of the infectious disease specialists here at Carilion. I'm here to talk to you about the epic battle of respiratory infections, bacteria versus viruses. So let's start with the case. We have a 19-year-old college student who presents in February with a 2-day history of fever, malaise, myalgia, cough, and loose stools. He reports his other 2 roommates are sick as well. He's been taking acetaminophen 1,000 milligrams up to 3 times a day with only mild relief. He's had his childhood vaccinations, but has not had any since starting college. He has no past medical history and does not take any prescribed medications. So on physical exam, his vital signs that shows that he's febrile, so 102.4. He's tachycardic to 124. Blood pressure is 110/70. He's breathing 20 breaths per minute, and his saturation is 96% on room air. He appears mildly ill, but in no acute respiratory distress. His posterior pharynx is mildly injected. Clear rhinorrhea is appreciated. There are no cervical nodes. His lungs are relatively clear without wheezes or crackles, and he has a soft, non-tender abdomen. The rapid strep is done, and it is negative. No other rapid diagnostics are available, and there's no immediate access to X-ray. So other than advising the patient to increase fluids, rest, and using antipyretics as needed, what would you do next? A, obtain blood for CBC with differential, procalcitonin, and C-reactive protein. B, obtain a nasopharyngeal swab for SARS-CoV-2, influenza A and B, and RSV. C, prescribe oseltamivir. D, prescribe amoxicillin clavulanate. Or E, prescribe prednisolone, a bronchodilator, and azithromycin. So upper respiratory tract infections are one of the top 3 diagnoses in the outpatient setting. And there's an estimated cost annually exceeding $22 billion, and that's not including influenza. It accounts for about 10 million outpatient appointments annually. And on average, adults will have a common cold about 2 to 3 times per year, whereas children will have it up to 8 times per year. So the etiology, as you can see, break it down generally into viruses and bacteria. For viruses, there are many that can do it, more than 200, and this is just a selection of probably the ones that are more common that you will come across. So rhinovirus, flu, coronavirus, RSV, paraflu, human metapneumovirus, and adenovirus. For the bacteria, obviously there are many bacteria that can. Again, this is more looking at the ones that are more commonly seen. So pneumococcus, mycoplasma, H. flu, Chlamydophila, Legionella, and Moraxella. Viruses are spread by aerosol, contact with infected secretions or surfaces, easily transmitted within closed spaces, so notably like within a household, dorm room, or even military camp. Bacteria can also be transmitted by aerosol or person to person, and certain exposures, whether it be travel, work, or social, can certainly help determine what pathogens may be more likely. So we're looking at clinical features. Symptoms often peak at 3 to 5 days, but can certainly persist all the way out to 2 weeks. And this includes things like fever, rhinorrhea, sinus congestion, sore throat, cough, and myalgia. In order to differentiate between viruses and bacteria, there's certain signs or symptoms that may help. So for example, for fevers, for viruses, oftentimes the fevers are quite high, all the way up to 105, whereas in bacterial, they tend to be lower. Can still go high, but tend to generally be on average lower than in viruses. Rhinorrhea for viral causes tend to be more clear. Bacterial can be clear, but can also be colored or have a purulence associated with it. For viral, sore throat tends to be mild inflammation, whereas bacteria tends to have significant inflammation, tonsillar enlargement, as well as an exudate. Cough for viruses tends to be dry, whereas bacteria tend to be more productive. The breath sounds for viruses, generally you're mostly clear, maybe a little bit decreased. You might have some wheezing, whereas for bacteria, since it tends to cause more of typically a lobar pneumonia, they'll have decreased breath sounds over the air of involvement. And it's also possible to have initially a viral infection and then get superinfected with bacterial causes. And so therefore, it's more important to be able to follow up with the patient to make sure that they're doing better. So there's certain tests that are available for rapid point of care in certain places. You have the ability to do a strep test, influenza A and B, RSV, as well as the SARS-CoV-2. Other things that need to go to a lab or other services available, the respiratory viral panel, RVIR, So this is a PCR test that's used to detect several different viruses, including adenovirus, influenza A and B, paraflu, the different types, enterovirus, metapneumovirus, and RSV. A monospot would be a blood test that needs to go to the lab, CBC with differential, a C-reactive protein, and then radiography. So for treatment, always emphasize supportive care. So this includes fluids and hydration, over-the-counter decongestants, antihistamines or throat lozenges, and antipyretics and anti-inflammatories. Staying hydrated is really important, mainly because there tends to be a fair amount of insensible water loss due to fevers, as well as breathing faster, and sometimes even with sputum production. If it is viral, either suspected or confirmed, then no antimicrobials should be used, as they will have no real benefit against the virus. For influenza, you could use oseltamivir if the symptoms are less than 48 hours and they're presenting with typical flu, or if you have a rapid test that is positive for flu. If you're suspecting bacterial or confirming it, then you're going to choose appropriate antimicrobials that are targeted specifically for that organism. And that's what we want to do for, amoxicillin or amoxicillin clavulanate or even azithromycin aren't necessarily the right drug of choice for everything. And so you want to be able to target the antimicrobial to what are most likely causes. Otherwise, you have to run the risk of inappropriate treatment, as well as potential adverse effects, and then prolonging the illness. So let's get back to the case and review some of the information that we do have. So we know that he's had 2 days of symptoms. It's a febrile illness, quite high fever. He does have close sick contacts. This occurs in February, which tends to be a little bit more likely to have respiratory viruses during the wintertime. He has a dry cough. It's not productive. Definitely has myalgias, which tend to represent a more systemic illness, or at least in systemic response of the inflammatory syndrome system, and therefore more likely to be virus. And then there's also loose stools, which tend to be more viral, although there are plenty of bacterial infections that can cause loose stools, including Legionella. And we know that he's had no recent vaccinations, so that includes not getting the seasonal flu vaccine, as well as the booster for SARS-CoV-2 or even primary SARS-CoV-2 vaccination. So what would I do? Certainly, I would underscore the importance of supportive care. I would certainly push fluids, say to use antipyretics or anti-inflammatories such as NSAIDs as needed, and make sure you're getting lots of rest. I would do a nasopharyngeal swab to do a rapid test if I have the ability for influenza, SARS-CoV-2, and RSV, or I would send it to the lab for RVIR analysis. And within the institution, that can be done relatively quickly. For the outlying institutions or offices, that may take another day to get to. And I would consider using oseltamivir in this setting because it's within 2 days of symptoms. He has symptoms very consistent with influenza, and I might consider doing that. And then I would reevaluate in 3 days to determine whether or not he's getting better. Because if he's not, then I have to think of other possible etiologies, which do include bacteria. If I have other tests that I had sent out, I'll be able to follow up on those as well. For some patients here within Corellian Clinic, we have what's called a viral symptom relief prescription. Some patients really like to have a prescription or something in hand after the visit. And in the case of viruses, we don't want to prescribe antibiotics. So here we can give them something that is a physical prescription to print out. And it gives it broken down into symptoms, how long can the symptoms last, certain instructions, medications that can be used, all of which are over the counter, and whether or not they truly need antibiotics. This is available on the intranet for those who are within the Corellian system. If you're not within the Corellian system, this is fairly easy to be able to adapt to yourself to develop one on your own, or there's also one available through the CDC online that is free. So take-home points. Not all infections require antimicrobials, so only the ones that are due to bacteria. Majority of respiratory infections are viral. Keep that in mind. And utilize clinical and non-clinical data to determine the most likely etiology. Finally, reevaluate the patient in a few days in order to determine the next steps in management and make sure that they are improving. Thank you very much.